Good morning, everyone. My name is Kevin Corbett. I'm the CEO of the Oklahoma Healthcare Authority, and I also serve as the Secretary of Health and Mental Health for our state. Thank you for being here today, and for those of you attending virtually. I appreciate you taking the time to learn more about managed care in Oklahoma and joining us today, taking time out of your day. Also want to thank High Plains Technology Center for hosting us here. It's a fabulous facility, and we really appreciate their hosting. With us today are my fellow Oklahoma Healthcare Authority colleagues. There's our panelists today, as well as representatives of our managed care partners. And let me introduce those to you first. That's Blue Cross and Blue Shield of Oklahoma, Oklahoma Complete Health, Humana Healthy Horizons, and United Healthcare. And also representing our dental plan partners are DentaQuest, Liberty Dental Plan of Oklahoma, and MCNA Dental. So today I want to provide you a brief overview of SoonerSelect, our new managed care program, followed by our panelists here who will give you a bit of information with regards to their specific areas of responsibility and expertise. We'll then open up to you for any questions that you may have. And after the meeting ends, our dental and managed care partners are available to answer any questions you may have. Let me start with the basics. A managed care organization, also called an MCO or a health plan, is an insurance company responsible for coordinating health services for our Medicaid members. Probably very similar to what you and your employers provide to your employees with regards to health plans. The MCOs provide whole person care in health home model to support members in obtaining needed medical, dental, and behavioral health care and referrals to social services to promote wellness, prevention, and management of chronic disease. As you may know, 40 states now partner with MCOs in their Medicaid programs, and they have seen better results in quality, access to care, cost predictability, and savings. Participation in the new SoonerSelect program will be based on a member's eligibility category and will include about 800,000 low-income parents, pregnant women, expansion adults, and mostly children. Enrollment for eligible members will be mandatory except for our tribal members. The SoonerSelect program will begin on October 1. Governor Stitt is dedicated to pursuing this SoonerSelect program as one lever to improve our population health in Oklahoma. His support for this initiative is unwavering. So all of us at the Healthcare Authority know how valuable the providers we partner with are in helping serve our student care members. Because of the dedication we share to improve the health of Oklahomans and your expertise in your respective fields, we knew we could not approach this transition without your input. Providers and other stakeholders were involved in the design of the SoonerSelect program and the managed care and dental contracts. We received close to 100 responses to our public request for feedback back in July and incorporated many of your recommendations throughout the process. Continuing in that spirit, we are holding this town hall and many others in the future to continue to listen to your questions and your concerns and incorporate recommendations that you provide. We hope you, the providers, will contract with each of our managed care partners to provide the greatest access to care for our Medicaid members in your community. Up next, let me have our panel of speakers provide you a brief update for their respective areas within the Healthcare Authority and how that relates to SoonerSelect. So let me introduce my colleagues first. First is Melody Anthony, who is our State Medicaid Director and our Chief Operating Officer. Erin Morris is our Chief Financial Officer. Dr. Karen Luce is our Dental Director. Dr. Terry Coffin is our Pharmacy Director. Dr. Mike Herndon is our Chief Medical Officer. And last, our Dr. Nathan Valentine is our Chief Quality Officer. After these panelists speak, we'll open it up to your questions, but for now, let me introduce Melody to give you some comments.
Good morning. I am so happy to be here. This is like my 4th trip to this facility, and I just love the way that they are accommodating to the needs of the community, and this is one of my favorite places. As State Medicaid Director, and especially as Chief Operating Officer, I have what we call senior care operations. And that includes all the operational functions of the Medicaid program, and also will be the facilitator through our implementation lead, Trailer Mays, in order to work with all the plans to transition the different areas that are in operation, mainly pharmacy, which Dr. Cochran will touch on, federal and state policy authorities, which we need in order to partnership with our managed care organizations in order to move the delivery system. We have provider engagement. Amy brought us here. This is her way of making sure that we have the provider network, and the provider network is in constant communications with our new partners. Tribal government relations is part of our implementation transition, along with some other areas, behavioral health. Every area of Medicaid that touches a member will be part of the transitional team that lives in Sooner Care operations.
Good morning, everyone. Happy to be here. My name is Aaron Morris. I'm the Chief Financial Officer with Healthcare Authority. I've been with Healthcare Authority for about 15 plus years, experience mostly in finance, but worked throughout the agency. So I have a pretty good background with the Medicaid program. I'm excited about our new partnership. As you'd expect, as a CFO, you know, a big part of our role is budget and accounting, but we do have other pieces to the financial team. We work on rates and reimbursement, federal reporting, and on the contracts that will guide this process with the plan. So we also have a IT piece, which is obviously the technology has to be right. It's really important to get this right with the plans and for our providers as well. So as the CFO, you know, a big part of my responsibility with the plans is rates and reimbursement, as we said, as well as the capitation rates that will be paid to the plans. And then the structure of the reimbursement process, which we'll work with the plans on as well. With that is also our supplemental payments that we run for hospitals and other providers that we are working, and one of our priorities is to preserve those payments. So happy to be here.
Good morning, everyone. I'm Dr. Karen Lewis. I'm the Director over Dental Services. I currently have oversight over dental prior authorizations and policy, and I also work with our legal department with grievances and appeals and ensure program integrity. And I'll continue to have oversight over these areas with our partners in health, with the dental MCOs. And I'm very excited to work with them and to ensure improved outcomes for our members and ensure continued quality care. Thank you.
Good morning. Terry Cochran, Pharmacy Director, as Kevin and Melody had mentioned. So I'll support the pharmacy services at the agency. That will include things like drug utilization review, access, reimbursement, pharmacy help desk, things like that. So anything pharmacy related would roll up under that department. And we've already started supporting the plans and look forward to doing more of that as we work into this process. So for pharmacy needs, I would be the one to talk to.
So my name is Mike Herman. I'm the Chief Medical Officer. I have 21 years of clinical experience practice, 3 of those in a rural setting and 17, 18 in an urban area. I've been with Medicaid 15 and a half years. I've been the Chief Medical Officer for 5 years. My responsibilities, in addition, I do have oversight of the dental and quality units. So we will be laser focused on quality improvement, quality outcomes with our managed care entities. That will be a big focus of ours in the future, and has been a focus of ours in the past. I also have responsibility and oversight over all the quality, part over all the prior authorizations and utilization management, suspended claims review, prior authorizations, and included in that is making sure that the guidelines that we use for making prior approvals and justifications for reimbursement are accurate and appropriate. And then all the codes that we cover, and as many of you know, those change frequently. Telemedicine codes is a great example. And so we constantly are reviewing what codes are available for reimbursement. So we will have oversight of that as well. And then any of the medical legal appeals that come through the agency or through our MCOs, I'll have responsibility for making sure that those denials are appropriate and done, and that the appeals process is fair and accurate. So we'll have, in scope, we'll have a lot of oversight from the dental quality and medical units for making sure that the product that we have through our managed care entities is done first class.
Hi, I'm Nathan Valentine. I'm a family doc and chief quality officer. I've been with the agency for about a year and a half. Prior to that, I was chief medical officer for a large FQHC in the state, and I had thought I was getting the hook. And I had quality improvement responsibilities at state level with the FQHC networks. So my role is to build up our quality unit and our capabilities and capacities to improve the quality of care, the measurable quality of care for our members over time in a continuous and significant fashion. And I'm really looking forward to working with our partners here to do this. There's a lot of good quality improvement tools, effective quality improvement tools involved in this process. And I'll pass it on to maybe questions next.
All right, thank you, Nathan. Thanks, panels. We want to keep our comments short to allow you to have the opportunity to ask any questions of the panelists. So we're going to start that now. I'm going to ask Melissa Ritchie to come up and kind of facilitate that, both for those in the room and those online. So you want to give us some instructions how to do that?
Absolutely. Thank you, Kevin. Thank you again for being here with us today and virtually. So as you said, we will now open the floor to questions for our panelists. Please raise your hand if you're here in person, and I will bring you a microphone to use. For those of you joining us virtually, please submit your question in the chat function, as we are already starting to receive some of those questions coming through, and we will ask your question to the appropriate panelists, or our online monitor will answer your question as it comes through. Do we have any in-person questions first?
Hi, I'm Dr. Susan Davis from Laverne, and I am a senior care provider dentist. And I congratulate you on the way that you administer the Oklahoma Healthcare Authority. Now they are run on 5% overhead. They do an excellent job, and I congratulate you. Why will it be better to take Oklahoma money that is run under 5% overhead and send it out of state under 15% overhead? And how will that benefit the patients of Oklahoma, especially the children? I have other questions also, if I can answer this.
Thank you for that question. And we received that question many times. First of all, as you know, we do run a very efficient program at the Healthcare Authority. I came 18 months ago, and I was amazed at the quality of the staff and the quality of the operations we run. We run primarily what was referred to as a fee-for-service business, as you know. It was always the intent of the governor to move to a management of care or a care coordination model. And that's been his unwavering view. As most of you know, our health outcomes in the state of Oklahoma are not where we desire them to be. We have been 46 or lower in state health outcomes for our citizens for many, many years. And his entire campaign and his entire focus is on making Oklahoma a top 10 state, and that includes in health outcomes. So this is a move for health outcomes. The method in which we're trying to do this is to partner with those that have shown expertise and capabilities elsewhere to assist us, the Healthcare Authority, in being able to do that. You're going to meet the health plans here today. We selected 4, as I mentioned, on the medical side, 3 on the dental side. Each of these plans have Oklahoma operations. So when we talk about money leaving the state, a substantial portion of the money that we will pay them is, first of all, goes to providers. And any administrative costs, a large portion of that stays to employ Oklahomans. Right now, we employ about 600 members at the healthcare authority. Between the health plans and the dental plans, that's probably going to be close to 2,000 more employees serving our members in the state of Oklahoma. I think that's a good thing. It's all on the basis of care coordination. For us to move to a care coordination model, whether it's internally or through our partnerships, will increase the cost of administration for us to do that. What we're planning on doing, though, is redirecting the spend that we currently have today on the most effective and the most efficient use of healthcare. We know that we have utilization issues with regards to emergency rooms and things of that nature. So this is all about a redistribution to achieve outcomes, as well as some level of cost predictability. So that's the reason we are doing this. So thank you for your question.
Okay, thank you very much. Just as historical background, when we tried managed care before, they say that reimbursement rates won't go down, but in other states, every time reimbursement rates have gone down when they go to managed care. And last time we tried managed care, I can only speak to the dental. We had 1,000, well, now we have 1,000 dentists who serve the children and adults of Oklahoma. Last time we tried managed care, it went to 100. And so that made it very difficult for those children to receive care, especially in rural areas. My question is, I see about 12 SoonerCare adult emergency patients for emergency extractions a month. Is that not going to cost more for those patients to go to a hospital emergency room, because that's where they go when they can't get to a dentist? Thank you.
Yeah, thank you for that question. You're right. We did try managed care in some form or fashion about 20 plus years ago. Lots have changed in the last 20 years. I think we'd all agree that there's been lots of innovation and advancement taking place. That includes in healthcare and in managed care as well. We have certainly taken into consideration what we did in the past, as well as what these other 40 states have been encountered. We've taken the best from all and tried to avoid anything that would cause any concern, including what we did in the past here in Oklahoma. So, like I said, we spent a great deal of time crafting our views in terms of how this could really work in Oklahoma, with the input again of others around the country. We feel like we've designed a program that will not only allow us to be successful for what we're trying to achieve, but to avoid the problems of the past. We're working closely with our plans on that same basis. They understand the expectations we have. One of the things that has been a question that we've received many times is this a move such that the healthcare authority will not have a role in place once this takes place? Nothing could be further from the truth. Our role continues to be, we own and own the responsibility for the Medicaid program in the state of Oklahoma. All of these individuals have a role going forward in terms of making sure that we're accomplishing the objectives that we're setting out, both for ourselves as well as our health partners, but more importantly for our citizens, that being our members. We made a commitment to our members, and we're going to continue to honor that. So, thank you for the question.
I'm now going to ask the panelists a virtual question. I already have signed executed contracts with 3 of the 4 SoonerSelect partners. When should I expect to hear from all managed care organizations?
All right, so clarify again, they've already signed with how many?
3 of the 4.
Okay, so they need to connect with the 4th one?
They need to connect with the 4th.
Well, if they would chat who that 4th one is, they are in the room and we can get them connected immediately.
We have that information, so we'll
Yeah,
get them connected.
That's the best way. Anyone who needs to connect with any of our new partners, medical or dental, we have some information on our public website, and we also have an opportunity for our partners and even our members to reach out and ask us specific questions, and we will make sure that all of those are addressed timely, and that if we need to personally connect you with one of our many new partners, we will certainly do that as quickly as possible.
Thank you. Is there anybody in the room that has a question?
Landon Heiss, CEO of Alliance Health Woodward Hospital. From what I understand, the Healthcare Authority, one of their own advisors, has said that to achieve the cost savings under the managed care plan, Oklahoma will need to reduce Medicaid services by up to 40%. First of all, is that accurate? And second, how do you think patients will react to the insurance companies when they tell them they can't have these certain services?
Hello, so yeah, I'll start, and if Kevin wants to jump in, I'll let him, I guess. But yeah, I'll start. So we work with Mercer, our actuary, to set rates. They use assumptions to establish this reasonable capitation rates that will have to go through a CMS review and approval from their actuaries. That is all about setting reasonable and appropriate rates to pay our managed organizations to run their program and achieve some efficiencies. 40% is definitely not the reduction in spend for the Medicaid program. That's an assumption around certain rate cells, which are basically our members and demographics, for potential reductions in utilization of inpatient or ER services. That is not an individual hospital specific number. It's aggregated. Overall, you know, the net reduction in spend for actuaries that our actuaries prepared was about 10 to 12%, which matches somewhere in the neighborhood of what we expect administration to be. They can achieve these efficiencies in many different ways. That doesn't necessarily have to come through a reduction in inpatient services. But as Kevin mentioned, you know, our focus is to improve the healthcare of Oklahomans, to improve outcomes. So one of the ways we do that is to shift the spend. We want to focus on primary and preventative care. We want to invest in that. And there are potentially unnecessary services being performed that are higher cost services. And if that shifts some of that money, then it leads to better outcomes. That's a goal of our program. So we'll partner there. But again, that's a rate setting assumption. If a patient goes to a hospital, goes to a provider, a claim is filed and it's appropriate to be paid, the claim will be paid. So just want to make some or get some clarity on that.
Sorry, one more. A couple more. Is there demonstrable evidence that MCOs do in fact provide budget stability and improve healthcare outcomes as claimed by proponents of the plan?
So yes, absolutely, budget stability. I mean, we will pay them a set fee. They'll manage the claims for those members. So budget stability for the state, absolutely. There is demonstrated evidence and literature that exists to say that there's efficiencies achieved by managed organizations as well. That our actuaries cannot, you know, create assumptions based on no data, no evidence. Those have to be reviewed and approved. And so when they're creating those assumptions, they're using literature, they're using historical evidence, they're using other state experience to create those. So there is literature, there is historical evidence, and we're partnering with them to achieve that goal.
What will happen if legislators decide not to fund SoonerSelect proposal?
As you know, the legislature does have a responsibility to set a budget, and we're part of that. We've made our budget presentation, and what we presented to the legislature was our entire Medicaid program and the budget for that. This is a portion of that is encompassed in that overall budget. It's not an increase, it's just a portion of that we're going to utilize our managed care partners and pay them that amount for purposes of running our program. Obviously, the legislature has their right to approve a budget or not approve a budget. That process is still underway. We haven't seen anything that would suggest that our budget is not being considered favorably, but that's still their obligation. So.
Okay, our next question is from one of our virtual participants. I serve children. Are the families allowed to pick which MCO they are assigned to, or will they be assigned based on some other factor? For example, age, geographical area of Oklahoma, income, etc. When will families find out what plan they have and what services are covered under each plan?
I should have brought my eligibility team with me. Let's see. So what will happen, the way it's planned currently, is when you are notified that you are eligible to pick your new managed care plan, you'll get a notice from us. And in that notice, you will be able to compare all 4 medical plans and the 3 dental plans. And then the healthcare authority maintains the responsibility of certifying the eligibility for the population. And we will be responsible for what they call choice counselors. So the members can call in and talk through the best option for the entire family. Every plan will be statewide. So you may not need to worry about a geographical area where your primary care provider may not be available. That's one of the reasons why we're making sure that the health plans have a list of all of our current contracted providers, so they can go and make sure that they are part of the plan moving forward after October. So we will be responsible for making sure that those connections for those kids and for the entire family is what the family needs, and they'll be aligned with the appropriate delivery system, the appropriate plan.
I'll take another virtual question. Where do providers find the rates for reimbursements? Behavioral health providers include therapy, groups, case management, and recovery support.
The current schedules are on our public website. I can tell you that one of the things that we require our plans to do is to match our current behavioral health fee schedule. The fee schedules for the individual plans will be available from them, but also we are trying to also be able to get a copy of those fee schedules so we can assist the plans in trying to expand and contract with the network.
Is there anybody here in person?
My name is Alyssa. We have a mental health counseling office here in town, and I kind of have a day-to-day on more of the questions on the day-to-day from both sides, because I know that we are going to have some of our patients come in and they're going to ask us to help them get set up. So I kind of need to know. So they'll receive a notification and then they choose a plan. When they get their new card, is it going to say SoonerSelect, or is it going to say the new network that they're a part of?
It's going to say Humana, Blue Cross Blue Shield, because that is their actual insurance coverage. We are just responsible for making sure that the oversight of that new delivery system is in compliance with what we put in the RFP and what the feds require of us as oversight agency. So they will get the actual card from the provider.
Okay, and so then on the billing side of things, we will go through the particular portal for that company. As far as billing, we will no longer use the OHCA website portal to do claims.
Yes, one of the things that we will be working through with the provider network and with our new partners is making sure that anyone who is a provider for any of our new plans has a way to communicate with that plan through their portal, and the claims will go through their system, and then they are required to send that information to us, because part of our oversight is to monitor the turnaround time on the claims payment, the denial percentage, and work with the plans to make sure that those claims are paid appropriately, timely, and they're in compliance with the coverage that is required by us.
Dr. Liz, I have a question for you. How will patients in current orthodontic treatment approved by SoonerCare Medicaid be paid? Will new authorizations be required, or will those already approved be rolled over to whichever plan the patient without new claims authorization?
So the first part of the question, all of the plans must follow the OHCA policy still. So prior authorization will be the same. And can you repeat the second part of that question, please? Oh, yes, sorry. Thank you, Erin. The PAs will be rolled over. PAs within our contracts will be eligible for 90 days, but for the orthodontic, if you're paid for that year, then you are paid at the beginning of the year and required to get that treatment. So yes, the same prior authorization will apply.
What is the anticipated start date for SoonerSelect? Will there be any lapse in coverage, or will OHCA continue payments up until SoonerSelect plan begins?
Okay, so right now, our plan, and working with all of our providers, plus the federal, our federal partner, is that SoonerSelect will actually be the delivery system for the population starting October 1 of this year. Prior to that time, you will, the members will still be part of our delivery system. If you enroll with, I'll just use United as an example. If you, in August, when you receive the information about it's time to choose your plan, you go through the choice counselors and you choose United. Up until the time you choose that plan, until the day that the plans are active, which is October 1, we are still responsible for your medical care. So after October 1, you will use the United card and you will go to the provider that you have chosen when you align with United as your delivery system, as your medical provider.
So a follow-up question is, how often will Medicaid recipients be able to switch plans?
So this is called the initial enrollment. So we are required for anyone who enrolls between August and October 1, they have 90 days after October 1 to determine that they made the right selection. So if they chose United, but then they decided that it was more convenient or the policy was a little richer to go with Humana, they can change in that first 90 days. After that, they are locked in. And then every year, we will do a new open enrollment for anyone aligned through our health plans. And they will have choice at that time to change plans or continue with the plan that they've had that past year.
If plans have caps on speech, occupational, and physical therapies, how are parents expected to choose?
Say that again.
If plans have caps on speech, occupational, and physical therapies, how are parents expected to choose?
You mean caps as in limitations of service?
I'm assuming that is correct. They didn't go into any detail.
Okay, so just as today, we have limited benefits for our population, but we also have the authority to do what's called a medical necessary override of our benefit package. The health plans will have that as well. So whether it's occupational therapy, speech therapy, physical therapy, there will be an opportunity, just as it is today, for additional benefits because of the medical necessity of the need of that member.
Last question from me. I have oral surgeon friends who are very, very concerned, and I'd like to read this because I want to get it correctly. If managed care Medicaid is implemented, oral surgeons will be forced to follow CMS rules and use CPT medical billing codes to bill hospital-based procedures, which would be an estimated 65% less than current OHCA fees. This will force oral surgeons in Oklahoma's only oral surgery training program at the OU College of Dentistry to immediately cease treating Medicaid patients. Do you have any plans to help this problem?
Dr. Lutz, as far as the CPT versus the dental codes, do you want to address when it's appropriate to use CPT versus dental codes? Can you address that? And then I'll take it from there.
So the CPT codes will, The CPT codes will be utilized for many surgical procedures, but CDT codes will still be used for procedures like simple and surgical extractions that are routinely done in the office.
So it is it's appropriate to use, CPT codes when medical procedures are done, maxillofacial surgeries and procedures, that's what's appropriate is appropriate. And to bill otherwise would not be ethical or appropriate to do. So I'm not quite sure, what the coding question is about, but, we will follow, what the standards are in the area of practice, whether it be dental, therapies or medical. So we will follow what the standard practice codes are. And like I said, for medical, it's CPT, for dental, it's dental. And I would like to circle back to your first question, if you don't mind, and just let you know that the Healthcare Authority has a budget request to expand the services for adults to a limited benefit, which would include cleanings, it would include restorations, dentures, and it's not an expansive package, but we are planning, and if our budget is approved, we will have an adult benefit better than what it is now for just a simple extraction. So I want to let you know that. And I want just to comment on kind of the prevention aspect. 11% of our 2-year-olds and less seek dental care right now, which is not good. We must improve that. And that will be one of the measures that we will be monitoring for our dental benefit plans is preventive care has to start, improving dental care throughout the state of Oklahoma, not just for adults, but for children as well. So preventive services to keep people from being in your office with multiple decayed teeth is the go.
Sorry, I thought of another. Currently, as an LBHP, we have different reimbursement rates than a state agency does for mental health. And we only can see patients under Medicaid that are 18 or under. Is this going to change that, where independent LBHPs can now see adults, where at this time they can only go to, we have to refer them to an agency? And then I think what the cap might have been that she was talking about is currently a patient can only have 4 mental health visits per month. After that, they have to wait until the next month. So if they come on a weekly basis, that's fine. If they came once or twice a week, they can only come to 4, and then once they get that 4, that cap is met, they have to wait till the next month. Is that going to be eliminated? And then we currently have to do treatment plans through PICUS, where we don't have to do that with insurance companies. Are they going to do away with PICUS, or will we still have to do the CDCs through that?
Okay, I did bring my behavioral health expert with me. Trailer, would you mind?
Sure, do I need to get mic'd up or? Okay. Hi, Trailer Rains. Yeah, so to answer your question, the plans have opportunity to go above and beyond what we do currently in senior care. So we've actually received a lot of questions from them on, can we cover LBHPs and independent practice for adults? The answer is yes, if you wish to do that. So we pay them a capitated amount every month, and within that, they can do what makes the whole person better. We specifically believe in, integrated care with having LBHPs in a primary care setting, for example. So we're all for the plans having that flexibility. With the PICUS question, the plans will be required to still utilize that customer data core information, because the state gets a lot of very valuable outcome information from the use of the CDC. So you want to go through PICUS, but they'll use a version of the CDC through their own. Did I get all of them?
And the limited visits.
Oh, they also have flexibility to go above our limits. Plans can't go, they can't restrict more than we are right now, without us specifically, approving it through them, but they can go.
Thank you, Taylor. Sure. What will school-based services look like in the fall of 2021? Will all school therapists, along with the districts themselves, need to be contracted and credentialed with each MCO? Will there be anyone helping the districts with this process? So the first question, what will school-based services look like in the fall of 2021?
from a Medicaid perspective or from an open school perspective? I'll do the Medicaid one. The school-based services that we provide today will be required to be provided by our managed care partners. We met with the Department of Ed just this week to talk through how they would interact with the health plans as far as IEP services, as far as services provided in the school after hours, and they also have a vendor called PCG, I think it's Policy Consulting Group. They are currently contracted with the Department of Ed and have enhanced some of the ability of the schools to actually work with us to draw down additional federal funds for the Department of Ed. And they are committed to working with the school districts in order for the school districts to be able to continue all the school-based services that will now be transferred to the managed care plans. It should not change.
Hi, good morning. My name is Scott Hubbard. I'm an orthodontist here in Woodward. And I guess specifically, first off, specifically the orthodontic unit, really just a round of applause to Dana and her group. It's really a streamlining thing. And so one of my questions is how will that change? Will we specifically be dealing with, again, I'm going to say her name is Dana and the rest of that unit, or will there be others that will, with the planned carriers, will we have to deal with each one of those for questions, things like that?
So thank you for that question, and thank you for the compliment. We do have a really wonderful dental unit team. That team actually does reviews for authorizations about all of the different, not just orthodontic, all the different areas, but thank you for that. So after managed care, yes, you would be dealing with whatever plans you choose to work with. We will still keep our dental unit team. They will have similar jobs, but not with the plans doing that same thing. They will also be learning new jobs, but we will still retain our dental unit in more of an oversight capacity.
Okay, thanks, Dr. Lewis. I have another question. So with the, I'm specifically thinking about surgical type cases, cleft lip, cleft palate, orthodontic surgery. So will those services still be provided? So I know that's a concern in other states, visiting with colleagues that, in fact, they're pretty envious of us in Oklahoma that are able to do those more extreme types of quality care through surgery and orthodontics. So will that change?
So again, services are not going to be reduced. There cannot be any restrictions without our approval.
So that's not specific for each plan. OHCA will still have oversight of that.
We'll have oversight over all three plans, yes. And our RFP, it outlines the procedures that coverage cannot change, and a lot of the prior authorization cannot be more restrictive.
Okay. And then one other question, if you don't mind. As far as with eligibility, again, specifically thinking about orthodontic side of it, will there still be the 30-point system, those types of things?
Absolutely. They will be following our policy, and that is in our policy.
All right, thank you.
What changes do providers need to be making now to ensure that our systems can handle this new model?
Okay, I heard the first part. What changes should providers be doing now?
What changes do providers need to be making now to ensure our systems can handle this new model?
Dr. Hunter, would you mind taking that as a provider?
I would say, as a provider and was a participant as a provider in our previous managed care, as well as was part of the HMO worlds. I have said, and I think it's true, that providers who are are doing their job and doing it well will continue to do just that and will perform very well with the managed care programs. Especially when we get to the value-based purchasing, with our fee-for-service and value-based purchasing, providers who are doing their job and doing well are going to fare very well in managed care. I believe that now, and I think I'll still be believing it in 5 years. You do your job and do well, and you're going to do just fine in managed care, if not better. So keep doing a great job taking care of your patients, and that's it.
So a common question we are seeing from our audience virtually is, if we have a contract with OHCA, do we have to contract with each payer individually?
Can Dr. Valentine add to that?
Dr. Valentine?
I just wanted to add to the previous question if I could. So I think, having traveled the state and talked to multiple practices and multiple sizes about quality improvement, I think that there are many practices, the majority of practices already have quality improvement infrastructure of some kind. We have all kinds of reporting requirements that are already in place. So there's a number of practices that won't have to change much. It'll just need to, there might be times when you have to focus in on an indicator and improve something so that you can get that value-based benefit based on the reimbursement practices of the plan. There will be a minority of practices that, based on what I've seen across the state, that really don't have a whole lot of quality improvement infrastructure, meaning there isn't someone whose job it is to make sure they're reporting on the indicators on a regular basis and improving things on a regular basis. They're just once a year compiling the information and sending it off to the authority. And then for those practices, there may be some adjustments that will need to be made, but that's going to kind of play us out over time as we find out what the actual payment relationships are between the providers and the plans. I'm sorry, go ahead and repeat that question for us.
Sure. If we have a contract with OHCA, do we have to contract with each payer individually?
And the answer to that question is yes. We are still responsible for the screening, the required screenings, and looking at the credentials of the individuals, which is why we shared, as I said previously, we've already shared with the plans our provider network so they know who to go talk to in order to be statewide coverage for our population. But the plans will be paying the claims, the plans will be submitting encounter data to us so we can have the oversight to make sure that the services that are being provided are in line with our expectations. So yes, but one of the things that we are currently working on with each plan is to come up with a way for a provider to do one document, yet to be determined, that would apply to all plans that you want to be contracted with. So we're trying to decrease the administrative burden as much as possible and give the providers the opportunity to work with all plans that will be part of our network in October.
Any other questions here? Any questions?
Sorry, I said no more questions. It sounds like to me like the Oklahoma Healthcare Authority is still going to be doing an awful lot of work. Why can't we do this without involving the other people?
That's a great question. Not one that we haven't heard or not one that we haven't explored, quite frankly. Personally, I looked at that when I first came in and talked to the governor about that. That's a significant undertaking to get to the point where our partners are today in terms of investments and really transforming the healthcare authority into a MCO in and of itself. The level of investment, the level of experience that our plans have will take us a long time to do it. Not impossible, but it would take a significant amount of investment, significant amount of time. And quite frankly, where we have been with health outcomes, taking more time is not the answer. We really need to try to take whatever opportunities we have to change that dynamic. And that's partnering with experts, regardless of whether it's an MCO or anything, partnering and extending ourselves to be able to deliver on our mission. That's what we're doing at the Healthcare Authority. We're still in charge. We're just asking the health plans to come and be part of our organization and make us a better state than we are today. So we're going to utilize their expertise, their experience. But yeah, we certainly have the ability to do that. I think it would be one that would not be the most wise question or answer to take at this point. So.
If a patient comes to an appointment without their card, will there be a portal to look them up? We touched on this slightly earlier.
I will answer for our new partners and say yes. Yes, they will be required to make sure that the providers they contract with, the members that are aligned with those plans, have the same access to verify information that we currently have today for members and providers to look at different things regarding each delivery symptom.
With value-based payments, will requirements be managed by individual plans or through a central system?
Yeah, I'll start, and you know, we want to give our plans an opportunity to be innovative. So there'll be some guidance from the Oklahoma Healthcare Authority, but the plans will also design their own value-based program, and we will monitor those. And we've asked for reports on progress. I don't really have specific requirements until, you know, a little more maturity of the program. But plans need to be able to be innovative, need to take different approaches, and we'll work with them to make sure that's successful.
When issues come up with one of the payers who have contracted with, who at OHCA is the contact to resolve these issues if they can't be resolved with the payer? If claims are denied inappropriately, where is the appeal sent to?
And yes, part of the oversight responsibilities that we will be maintaining is any concern that a provider or a member has with the plan, regardless of what the issue is, they will be required to work with that plan, and if that resolution is not what the expected outcome would have been from the provider or the member, that comes to us. It's part of our responsibility to make sure that just because we are not the ones with the provider network and paying the claims and doing all of the interaction with the members, they are still Oklahoma's SoonerCare members. They will always be ours. And so we have an obligation to them today, and we will have an obligation to them in the future, that we are there for them, and any issue that a provider or member has with our new partners, if they can't resolve it there, we will resolve it with the plan or without the plan, but it is ultimately our responsibility.
We have about 5 minutes left. We do have a follow-up question for Dr. Herndon. I need to know, how will our system handle a primary payer who is fee-for-service and a secondary payer who is using a bundled model?
I don't know that I'm the right person to answer that. Eric, do you want?
Yeah, I think I would have to think through that question and understand some context before I just responded. So I'd love to have a conversation, but I'm not sure I can answer right now.
Will one of our monitors reach out to that person? We can get their contact information. Are there any other questions for our participants here?
Just one other question, and I think I can probably speak for all the providers and for those of y'all that are here today, thank you. But I guess there's just a little frustration as far as, you know, being providers. You know, we, just like you spoke to earlier, this is for those in our communities, and we don't do it for compensation. It's for treatment of the people of Oklahoma. And so I guess, what encouragement can you give us that things won't change enough, that we're so frustrated that we can't continue treating those in our communities.
Well, you have, I would tell all the providers, you have my personal commitment that we are going to be maintaining this program. Like I said before, we've partnered with our health plans to assist us in our obligation, but it's our obligation. And so our role is to ensure that both our provider network and our member network continue to be in place and continue to advance forward. We have 70,000 providers in our network today. It's very important that that network stays in place. It's a key component of our launch that we have to have network adequacy, and that's just not numbers, but that's quality and that's relationships as well. So our provider network today and our provider engagement group is going to be very active with the provider community to do just that, to continue to maintain the highest quality partners we have and make sure that the access for our members is there. We all know in Oklahoma, our health outcomes are due to a number of things, one of them being access. And we've asked our partners to deal with that and help us be dealing with that. But it also has to do with providers and the relationships we have with you and others. So that's our commitment to our provider network, that we're still here. You know, we have a big role to play, and it's all of our responsibility to do that. So. Okay, so I guess that is the hook. So really, thanks everyone for being here, those online. We really do appreciate your time and value your feedback. I think we have some folks in the room that have made notes with regards to your comments, and we'll capture those today. In the coming days, we'll have a recording of this meeting, I'm told, posted on our website, so you can share that with others that didn't have an opportunity to participate. This is not the last of our town halls. We have several scheduled already. So our next town hall is scheduled in Duncan on April 1st at 1 o'clock. Then we'll be in Poto on April 7th. And we'll continue to add other locations and add those to our website that you can follow those along. For those that are here in the room, I would encourage you to take the opportunity to meet with our plan partners here today. We have all 4 plans. Health plans as well as all 3 dental plans. They have information out in the foyer here for you to take a look at and ask any questions you have of them. Again, they're our partners. We deal with them routinely and frequently, so they're an extension of us. So any question you ask them, you can ask us. Any question you ask us, you can ask them as well. If you have other questions, you can certainly submit those. I'm told that there is a form on our website. If you don't know what that is, that's oklahoma.gov/OHCA, and click on the link to today's town hall and you'll find the form. So again, we really appreciate the opportunity to meet with you today, and we'll continue to meet with you. But thanks for joining us, and have a great day and have a great weekend. Thanks, everybody.